Hello everyone, welcome back to the lectures, actually in the series of lecture on geriatric pharmacy. At the end of the day, I want you to able to describe age-associated trend in clinical hypertension. What are the features that are very special in older people as compared to younger patients who are having hypertension? I want you to be able to explain the classification system, okay, the most commonly used in the blood pressure in Malaysia. And also, I will also touch a little bit about overseas so that you can have an overall picture. And finally, to outline goals and therapeutics intervention appropriate for elderly patients with hypertension. This is very important because we want to know what is the goal of treatment in older people. Before we go further to know about the characteristic, the feature of hypertension, it is important for me to highlight why do we want to study about hypertension in the elderly. So this slide is important. This slide shows you that you can see the prevalence of hypertension is almost 70% in older people, more than 65 years old, and these are much higher as compared to the younger population, which is only 30.3%. So that what does it tell you? So you're gonna see 7 out of 10 people in outside there which having hypertension. Older people who are visiting your community pharmacy or who are coming to the hospital, who are coming to the ward. So it is important for you to learn about hypertension and how to treat them and make sure you know A to Z about this. Now you can also see here that slightly more than half of the population are undiagnosed. This can be very true in older people. And what is the most important thing as a pharmacist is we know that almost half of them who are given the treatment does not achieve the treatment goal. So we have a bigger role as a pharmacist to ensure that they have optimized treatment so that they can achieve the goal of treatment. And also in Malaysia, about 20% of the people have pre-hypertension. What is the implication? We as a pharmacist probably can provide advice and also intervention, non-pharmacological intervention, to ensure this patient group does not go into the hypertension. Isn't that prevention is always better than the cure? Okay. Now let's look into the blood pressure. I know this is actually a recalling session, but you still have to know this so that you can appreciate why older people has a different characteristic. Normal blood pressure means there is a normal blood flow to the body, organs, and tissues. You know, when there is a blood flow, the force of the blood on the wall of the arteries, there is a blood flow, the force on the arteries is what we call blood pressure. If the force increases, we know that the patient is having high blood pressure. So what is the definition of hypertension? There are various definitions of hypertension. So let's look into the JNC8, the 8th Joint National Committee of Hypertension, which is the most commonly used in overseas. But I want to tell you one thing. This is quite similar to the Malaysian definition of hypertension. I'm going to go through that one by one. But United States, US have their own definition. You'll be surprised later when I'm going through. European Union, okay, they have their own as well. All this I want to explain to you so that you are exposed in all these things. Okay, so basically JNC 8 and also the Malaysian guideline clearly says that anyone who has systolic blood pressure more than 140 over 90 diastolic is having high blood pressure. Okay, remember this. And the most important in older people is the increase of the isolated systolic hypertension. So older people tend to have what you call the diastolic blood pressure less than 90 millimeter mercury, but their systolic is high, 140, more than 140 millimeter mercury. It's something very special about older isolated systolic hypertension. Is something that is commonly seen in older people. And that is what on the characteristic I will touch later as well. Okay, so we have also hypertensive emergency and urgency, which are quite similar as compared to the younger population as well. So the most important things that you see in older people, I'm sure I have also highlighted in my previous lectures, are orthostatic hypotension. Very common in older people. In fact, a drug in a low dose also can cause orthostatic hypertension. So what is that? A posterior hypertension is defined as the sustained reduction in the systolic blood pressure more than 20 millimeter mercury, or 20 of systolic or 10 millimeter mercury of diastolic blood pressure from the lying position to the standing position. So for those who are patients who are lying and they stand, within 3 minutes of standing, when there is a drop of 20 millimeter of systolic or 10 millimeter mercury of diastolic, we can actually diagnose them having orthostatic hypertension. Why is important? When suddenly people is having hypertension, they will have dizziness and they might actually fall. Falls in older people, before falls, it may cause postural instability, and then if they are unlucky, they might fall or break their hips or anything in the body actually. So these are very dangerous. I'm always say to you, orthostatic hypertension is important for you to learn and identify as a farmer. Let's look into the classification of blood pressure, one of my objectives of the lecture today. The classification of blood pressure in adults, and the slide that you can see now is the classification based on the Malaysian guideline which was published back in 2018. So it's very clear. Hypertension is defined as more than 140 to 159, more than 140 millimeter mercury systolic, more than 90 diastolic. So you can see here the optimal blood pressure is less than 120, and those who are at risk is actually the pre-hypertension group, is 130 over to 139 actually. The classification in Malaysian guideline, we have 3 categories, stage 1, 2 and 3. Okay, the JNC7, we only have stage 1 and stage 2. In US, you're going to see it's slightly different. I'm going to tell you what is the cutoff value for blood pressure. Okay, so stage 1 in Malaysian guideline, 140 to 159. Stage 2 is 160, and anything more than 180 is stage 3. Isolated systolic hypertension, remember I told you earlier, more than 140 systolic, less than 90 diastolic. This is the classification of blood pressure based on JNC7 and JNC8. They follow the same thing. Stage 1 and stage 2. Quite similar to the Malaysian guideline. Only thing is there is no stage 3 in the JNC8 or 7. This is the blood pressure category or classification based on American Heart Association AHA guideline. Okay, this is US. You can see here, they already diagnosed patient is having hypertension. With patient already have stage 1 if their blood pressure systolic is more than 130 over 139. Remember in Malaysian guideline, 130 to 139 is pre-hypertension. It's not considered as hypertension. But in the US, it's considered hypertension. And in fact, in US, those who are in from between 120 to 129, the yellow color here, already considered as having elevated blood pressure. So they are more stringent. There is a study, we call it SPRINT trial, and this particular US is following the outcome of the SPRINT trial to support to have a stringent blood pressure monitoring and in fact blood pressure classification. All right, so you can see here anyone that is more than 180 millimeter mercury in systolic or 120 diastolic is actually classified as having hypertensive crisis. So the question now is, all these things that I've been telling you so far is all what you have known previously as a student. When you are studying hypertension, someone have already taught you. But what does this elderly hypertension have a specific characteristic? So do you think is very special hypertension in the older people, or do they present in a different criteria, different characteristic, different symptoms? So let's look into this now actually. So the age-associated trend in clinical hypertension, the first thing that is slightly different or slightly going to be special in older people is the sodium sensitivity increases with age, as does the hypotensive response to diuretic. So there are two parts here. One part is the sodium sensitivity increases with age. So I told you earlier, in older people, a small increase in the sodium content, a huge increase in the blood pressure. Another thing is, if you give diuretic to older people, there is higher chance for them get hypotensive response due to diuretic. We never give loop diuretic for older people. Yes, studies have shown that thiazide type diuretic is best to be given to older people. If you loop diuretic is going to cause a huge amount of water to be really taken out from the body, and that can cause hypotensive response due to diuretic. Another second special characteristic in older people is the isolated systolic hypertension, which I've already highlighted to you. It becomes more frequent than the systolic hypertension in older people. Third one is arterial stiffness increases. Arterial stiffness is the measure of how stiff is the artery. It's very important. When the artery becomes stiff, then we know there is an increase in the blood pressure as well. So the arterial stiffness increases as people get older. How to measure arterial stiffness? Of course, there is a clinical way of measuring arterial stiffness. We call it pulse wave velocity, biomarker to see how stiff is the arteries. When the artery is very stiff, we know that it's going to be very difficult to treat the patient. I mean, we give the drug accordingly. There is a greater incidence of endothelial dysfunction. You know this actually. As people get older, there is a endothelial dysfunction. Any changes in the endothelial dysfunction due to the release of radical oxidative stress, this is going to cause increase in the blood pressure. And another one is the frequency of white coat effect increases. You know what is white coat effect, right? Okay, so it's going to increase in older people. So those older people who go to the clinic or everything, they're going to have an increase in their blood pressure. But at home, everything is fine. And that is how to solve this problem. I'm going to touch that now. Okay, 5 things. So to summarize, there is an increase and decrease in certain things in older people. These are the characteristics in the elderly. What will increase? One is systolic blood pressure and pulse pressure, obviously. Left ventricular mass or wall thickness. So older people will have an increase in the left ventricular mass. Remember, long-term hypertension can cause left ventricular hypertrophy. So older people tend to have hypertension for a chronic long time. Usually, they will have in a younger age. Now you can see even young people as young as 20 years old already have hypertension. Okay, so arterial stiffness increases, I've actually explained in detail, and total peripheral resistance will increase in older people. So what does it increase? On the opposite, cardiac output will decrease, heart rate will decrease, by the way, the heart rate will decrease as people get older. Okay, renal blood flow, renal plasma, renin activity and angiotensin 1 level will decrease. These are important. In certain patients, it will increase. This, what we call here, is the aging characteristic. Arterial compliance and blood volume will decrease. This arterial compliance is inversely proportionate with the arterial stiffness. When arterial stiffness increases, the compliance will decrease. It's very normal logic, right? And diastolic blood pressure will decrease. Remember, I keep telling you, isolated systolic hypertension. So how to manage this problem? White coat hypertension. So that is why we offer automated BP recording, ambulatory blood pressure monitoring. Have you ever heard this? We will ask the patient actually where there was some kind of devices in the body, and we will actually monitor their blood pressure 24 hours. Automated BP recording is we ask the patient to do home monitoring, home blood pressure monitoring. Now you can buy a machine and just measure the BP themselves. Hypertension and hypotensive syndrome. These are two hypertension, hypotensive syndrome, that what I will say. So we will measure the postural changes in blood pressure, lying and standing position. Once we know patient is having high risk of orthostatic hypotension, then we can actually treat. We can reduce the dose of hypertensive agent accordingly. Inadequate response to therapy. So in older people, they might be on 2 or 3 medication, antihypertensive agent. You know that is actually, if it is not responsive, we should always check their compliance. Most important, Older people don't like to take medicine. Okay, for them, they say they're already at the end of their life, no need to take medicine. Perform past wave analysis. This is what I want to say earlier, isn't that? I want to know how the stiffness, the arterial stiffness, because this is actually can cause inadequate response to therapy. Trial of long-acting nitrate, sometimes that is the last option, or trial of spironolactone. This is when the patient is already having hypertension resistant. You must know how to measure the blood pressure. This slide shows the how to measure the blood pressure, how the patient should sit, and they should not talk, they should not cross their leg, cannot eat a coffee, at least half an hour. So all these things you guys should know by now. Pharmacists can know, must know by heart. In fact, if you're in community pharmacy, it is a good practice for you to ask the patient to come, and first thing is you measure the blood pressure. The moment you do that, the patient will feel connected to you because you're concerned about them. It's not going to take a long time for you to measure their blood pressure, isn't that? Ask them to rest and then measure their blood pressure. You relax for 3 to 5 minutes and then take 3 measurements at the 1 minute interval. Some people say 2 minute interval, so minimum is 1 minute interval. Okay, and you take the average of the last 2 measurements for your as a reading. All this is important. So read in this slide. Yeah. Treatment goal. This is the JNC 8 guideline shows. In fact, these are quite similar to the Malaysian guideline as well. That's why I like to show the JNC 8. Now it's time for you to know what is happening outside there. I know 4th year is only must look at Malaysian guideline, but why not learn something extra? I mean, the purpose I come and give my lecture is for you to learn extra. So why not you learn this actually? Okay, for patients more than 60 years old, which is the elderly, the target goal is less than 150 over 90. Remember this, eh? Elderly more than 60 years old, target is less than 150 over 90. Obviously, there are other component we are going to look. This is the treatment systolic blood pressure target goal for older people based on Malaysian guideline 2018. So patients more than 65 to 80 years old, target goal is less than 140. Remember, I told you earlier, more than 60 years old, based on JNC 8, it's less than under 50. This is a JNC 8. But in Malaysian guideline, anyone more than 65, between 65 to 80 years old, the target is less than 140. Slightly stringent, yeah? Very elderly population, more than 80 years old, the target is slightly lower, less than 150 millimeter mercury systolic. But those who are having multiple comorbid condition and special, geriatric have multiple comorbid, and those who are frail, frail is a very, very ill patients who can't wake up from the bed, who can't have activity of daily living, they're functional or cognitive impairment. Those patients who are institutionalized, those staying in the nursing homes, for them, we can consider less treat target. So we can consider this is all individualized, personalized, but you have to, when people ask you, you must give justification. But if the patient is fit, 65 to 80 years old, but if they are fit, just now I told you 65 to 80 years old, less than 140, but if they are fit, nothing wrong for you to have a lower target, which is systolic blood pressure less than 130. This is what Malaysian guideline says. Definition of fit, you can read this later, okay? Okay. So same thing here, I have actually listed down all the treatment goal, blood pressure goal from the Malaysian guideline. Easy for you to see. Those who have diabetes less than 140, in fact, majority is less than 140, except for those who have proteinuria more than 1 gram over 24 hours, and for those who have secondary lacuna stroke, secondary prevention for lacuna stroke, and left ventricular hypertrophy or renal impairment. If it is a patient who are 65 to 80 years old, fit, less than 130. If it is 65 to 80 who are not fit, less than 140. More than 80 years old, less than 150. Very simple. How to treat hypertension? We know that hypertension is actually very common in older people, and we know that hypertension is slightly special in older people. They have a special characteristic. But the question is how to treat them? How to treat hypertension in older people? Or you want to say, now, minor older people, you don't have to treat. No, we have to treat them, okay? The true approach in treating hypertension is the first is the lifestyle modification, and the second is the pharmacological treatment. We want to treat them using drug as well, but you have to be careful in certain things. So what is the benefit of lowering BP? You say, well, come on, I want to treat older people. Is there any benefit? Yes, there is a benefit. This is the meta-analysis of 68 trial, and you can see here, by reducing BP, blood pressure, we can reduce about 43% of patients having heart failure, for example. 11% reduction in mortality. So treating blood pressure is important. You can reduce strokes, 36%. The lifestyle modification is important in managing elderly hypertension actually. Is it reducing body weight is useful? So lifestyle modification in older people, weight reduction is useful. Reduction in sodium intake is very important because they have high sensitivity towards increase in the sodium. Decrease in the alcohol intake is important. Smoking cessation, regardless of young people or old people, everyone should you should stop smoking. Increase in the physical activity, not strenuous activity, as much as they can do. If they can only walk for 10 steps, because majority of older people is having osteoarthritis, rheumatoid arthritis, and knee pain and everything, if they can walk, you cannot force, because if you force them, they're going to have a pain in their knee, and that's going to cause increase in the stress, increase in the blood pressure. So actually it defeats the purpose, isn't that? Okay, increase in physical activity and inadequate continue first line treatment. So basically, these are the mechanism of how non-pharmacological treatment can actually help decrease in the blood pressure. Okay, these are, you can see clearly actually. We can take an example here. Body weight management is going to affect the renin-angiotensin system actually by causing increase in the sodium reabsorption, increase in vasoconstriction, and this is going to cause increase in blood pressure. So by doing this, by reducing blood pressure, we are actually counter-reacting all these aspects, and this is going to helpful in decreasing the blood pressure. Psychosocial stress management, if you have the stress, what can be done? Meditation, relaxation. For those who have problem in healthy diet pattern intake. So basically that by reducing 1 kilogram of weight, it is going to helpful in reducing at least 1 systolic blood pressure. What is the impact of reducing 5 systolic blood pressure? I will show you in the next slide. So reducing salt intake of less than 2.3 gram per day can help to reduce 5 millimeter mercury of systolic blood pressure. And obviously DASH diet, the diet which is rich in fruits, vegetables, and low-fat dairy product are very important in the control of hypertension, and there are a lot of evidence on that. It's a Mediterranean diet actually. Okay, exercise, moderation of alcohol intake, and so on and so forth. So exercise 30 to 60 minutes per day or at least 3 times per week. Let's look how to treat older people using pharmacological treatment. What are the factors affecting the choice of drugs in the elderly? Can anyone tell me this? Maybe you can actually pause the video and think, what will be the factor? Is there concomitant diseases? Let's look one by one. The first one is the cardiovascular risk profile of the patient. Okay, we want to know how is it a primary prevention or secondary prevention, and what are the other concomitant diseases. This is going to be very important. Coexisting disorders, target organ damage. If the patient already have any target organ damage, okay, is there any interaction with other drugs used for concomitant conditions, and tolerability of the drug. Older people, they might have a higher risk of ADRs, so we want to ensure the drug is given is something that can tolerable. We don't want to give a drug causing them to have hypertension and NR actually falls. And finally, the cost of the drug. This is the last choice, because if most people are taking drugs from the government hospital, we don't have to worry. You can see here for patients in UK, more than they actually have a different, the cutoff value is more than 55 years old. Anyone more than 55 years old, the first line treatment is calcium channel blocker. Less than that, the first line is actually ACE inhibitor. If the patient started with calcium channel blocker, they can actually recommend to start add in ACE inhibitor. If it is, then you can add in thiazide type diuretic. It's still not okay, we know it's a resistant hypertension, we can add in spironolactone. This is the recommendation. This is just to let you know, you don't have to remember this, okay? And this is the slides on the GNC8 treatment guideline. Okay, very simple. Patients who are more than 60 years old, the target goal in GNC, remember the slide actual target goal is less than 150, and their choice is actually thiazide type diuretic, ACE inhibitor, ARB, or calcium channel blocker, or in combination. Okay, if the patient is having very high blood pressure, we give combination agent, 2 combination in a lower dose. That is the way we work actually. So treatment approach, if it is stage 1, we give them observation period 3 to 6 months. We don't give drugs immediately the patient is having stage 1 hypertension unless there is a target organ involvement is already evident. Follow-up should be every 2 monthly actually. And in newly diagnosed and complicated hypertension and no compelling indication on no other concomitant diseases, single drug with low dose. Remember this, newly diagnosed, no other concomitant disease, we give only 1 drug with low dose. These are the choice of antihypertensive drugs in patients with what you call concomitant based on the concomitant disease. So let's focus on the one in the red box, which is older people with no comorbid condition. Very clear. Thiazide type diuretic or calcium channel blocker is the evidence that we should give for older people. Okay, but in very elderly, more than 80 years old, there is evidence to give ACE inhibitor because the Harvard trial, I mean, this is a trial, you don't have to know, but just to share with you that Harvard trial used the indapamide plus ACE inhibitor for the treatment of very elderly population. That's why you can see here there's a plus in ACE inhibitor. Obviously, calcium channel blockers still can be given. The evidence are there. For patient who does not tolerate to ACE inhibitor, we can give them ARB. Okay, we don't give beta blocker and peripheral alpha blocker for older people unless they have previous history of cardiovascular diseases or they have heart failure, then we can start on beta blocker. But we should monitor the heart rate. The effective antihypertensive combination used in outcome in clinical trials. So if you ever wanted to give a combination therapy, the best combination is thiazide type like diuretic plus ACE inhibitor. This is what they use in the Harvard trial. Hypertension in the very elderly trial. Okay. We don't give furosemide. Loop diuretic is no for older people. I have highlighted that. So how to follow up? Do we older people also we have to follow up? It's very important. Very simple. Patients should return for follow up every monthly until the BP goal is reached. But in Malaysia, sometimes we ask them to come every 2 monthly as well. But the best is monthly. After BP at goal and stable, follow up 3 to 6 month interval. Okay, once they become stable, you give a drug, stable, you follow up 3 to 6 months. Obviously, they will come monthly for take the medicine, but this is hospital monitoring. More frequent visit if they have hypertension stage 2 or with complicating comorbid condition. I mean, if they have multiple comorbid condition, we ask them to come more frequently because it changes more rapidly. Always continue to encourage self-BP monitoring in older people. Ask, advise them on non-pharmacological treatment. Serum potassium and creatinine should be monitored at least 1 to 2 times per year. At least. Very important because most of the drug is going, that the pharmacokinetic changes, there is a reduction in the renal function, reduction in glomerular filtration rate, and the drug, actually those who are drug that is excreted renally might accumulate, and actually it can cause, some of the drug can cause renal damage. So we have to monitor serum potassium and creatinine. We already know what is hypertension. Why is hypertension is very important? What are the characteristic, special characteristic of hypertensive in older people? I've also touched how to treat older people, non-pharmacological treatment, and I also touch on pharmacological treatment. What are the drug that is suitable for older people? If it is stage 1 hypertension, give one drug with lower dose. You can start with calcium channel blocker, amlodipine 5 milligram OD, or you can also start with the for 2 milligram perindopril once daily. Increase the dose accordingly based on the blood pressure monitoring. These are some of the things that you can actually do in older people. Thank you very much, and I hope you have learned something out of this lecture. Okay, if you have any questions, you can always email me as usual. Thank you and have a good day, everyone.